COVID-19 clinical readiness and patient care teleeducation session for June 3rd, 2021. My name is Sean D'Andrea. I'm the Emergency Medicine Chief Clinical Consultant for the Indian Health Service. Thanks for taking time out of your schedule to join us today. We're going to start today with a clinical update from Dr. John Ihs, the Chief Clinical Consultant for Infectious Disease for IHS. Then we're going to move into the main presentation, which is a discussion of long-term COVID-19, the neurology perspective provided by Dr. Jeffrey Manival from Brigham and Women's Hospital. And we hopefully will have time for Q&A as usual, but please don't forget to share your questions at any point during the chat feature of Zoom. And if our presenters are able to get to them, they will. Otherwise, we'll save them till the end. And then we'll be closing out. Don't forget to complete the post-session survey for your CME credit. That will appear in the chat feature of Zoom. The ECHO team will be dropping that in there as we move through the presentation. As you may have seen in the beginning, this session is recorded and your attendance serves as consent to be recorded. The recording will be made available on the Project ECHO website following today's presentation. Please see the original email invitation for slides from today's presentations. And again, CME is available following completion of the post-session evaluation. And with that, I'm pleased to turn the call over to Dr. John Ihs, the Chief Clinical Consultant for Infectious Disease for IHS.
Hello, everybody. We'll get started with the talk now. So we've been doing these sessions for the last roughly 15 months, and we plan on winding down with our next session in mid-June. So this will be my last clinical update, and I feel a little sad about that, but I'm excited that we're kind of moving on with this pandemic. May I please have the next slide? There's nothing to disclose. Next slide, please. So let's talk about the virology and the variants and how they impact vaccines. So this first discussion is of the Pfizer vaccine. It was published by Liu et al. Earlier in May. And this is the group that had previously looked at the activity of their vaccine, the Pfizer vaccine, against the UK, the South African variants. And now they are doing a different project where they're testing different engineered S gene mutants for the California, New York, and the UK variant, plus this bad mutation E484K. And what they found was actually quite encouraging. So in terms of these recombinant viruses, they were able to produce high neutralizing antibody titers that were essentially equivalent across the board. So for the New York variant, neutralization was equivalent. For the California variant, just slightly lower. And then adding that 484 mutation from South Africa to the UK variant did not compromise neutralization. So really nice data from a group testing the Pfizer vaccine, showing that it works for what's circulating in the States right now. Next slide, please. Okay, and then how about the India variant? This group, Bernal et al., published this in MedRx IV, and they looked at the efficacy of a couple vaccines, Pfizer and AstraZeneca, against the Indian variant that has been circulating first in Maharashtra. We've talked about it before at this conference. And what they found was that the Pfizer vaccine was 93% effective against this UK variant, and 80 in the UK, and then 88% effective against India variant. So just a slight diminution in effectiveness. So really exciting that this works. AstraZeneca, in contrast, was only 66% effective against UK and 60% against the India variant. So not quite as good, but once you gave the second doses, the difference between the two vaccines was just a modestly impaired effect. So kind of useful data for us regarding the Pfizer vaccine here in the United States, that we do have protection. Next slide, please. And then in terms of clinical presentation, so leaving the variants behind, talking about the clinical presentation, mucormycosis has popped up as a big problem in India. So before the COVID pandemic, mucormycosis was already a growing problem linked to diabetic ketoacidosis. And it's primarily rhinocerebral mucormycosis. That's the fungal infection that eats away at the sinuses and causes brain infections, eye infections, etc. But they also were seeing renal disease. And they saw it with some atypical species that I've listed there, including that Rhizopus species, a new mucor species, and a couple other genuses and species that are difficult to pronounce. And this was published by Chakrabarty in 2014. What has been found is that mucor is popping up in India, especially involving the eye, the orbits. And there were 10 cases reported by Sarkar in a link that you can see at the bottom of the page there. And what they found that all 10 were diabetic, they had all received dexamethasone, and 9 had developed diabetic ketoacidosis. They treated them all with amphotericin, but they had miserable outcomes. 4 died, and only 1 had a good eye and systemic outcome. So a devastating illness. We do take care of diabetics in the Indian Health Service, so be aware of this risk, especially in the setting of DKA and in the Indian subcontinent. Not reported here that I'm aware of, but we should be really careful. Next slide, please. And then how about the new guidelines about monoclonal antibodies? Dr. James McCauley talked to us last session about the great success stories in White River using bamlanivimab, the monoclonal antibody, to prevent hospital admissions and and other serious outcomes like death from COVID-19 in people with mild disease. The indications for this new combo drug changed slightly. So whereas before we used a BMI cutoff of 35, we now use a BMI cutoff of 25 for giving this infusion, and pregnancy was added to the list. You can see that the older age is still there: CKD, diabetes, immunosuppressive therapy, chronic lung and heart disease, sickle cell disease, neurodevelopmental disorders, and then medical-related technological dependence, like a PEG tube or a trach. So be aware that there's a slight change in the indications from previously. Next slide, please. Okay. So how do these drugs, how do they fare against some of the variants? You can see that if you look at the last column, which is fold reduction and susceptibility, the UK variant, this drug combo is excellent. There's been no change in neutralization. However, the South Africa variant doesn't work at all well. There's a 215-fold reduction. Brazil variant, 46 fold reduction. New York variant, 31-fold reduction. Only the California variant that has that one mutation, ELF452R, has about a 9-fold reduction. Corresponded with Dr. McCauley earlier today, and he is thinking of possibly using more of the Regeneron product in his service unit. So it all hinges on what's circulating in your area. In our area, in our region, we're concerned about the UK variant, which is highly susceptible, and a little bit of California. So you have to look at your area and see what's circulating there, decide which drug to use. Next slide, please. So another nice update, the NIH now came out last week to say that they think that if someone has severe COVID-19 illness and they're already on dexamethasone or dexamethasone remdesivir, and they've been placed now on high flow oxygen or non-invasive ventilation, they recommend that we either give baricitinib, which is that JAK inhibitor drug, and then tocilizumab, which we've talked about multiple times before. So they want us to take our pick. They list them in alphabetical order. So, but this is a nice tool that you can now use with more confidence that the NIH has recommended it for severe COVID. Some of the panel members said, make sure they have evidence for systemic inflammation or rapidly increasing oxygen required. Other members did not. So just in general, they're recommending high flow oxygen, non-invasive ventilation, use one of these 2 drugs. So a new development. If you can't use steroids, you can give remdesivir plus baricitinib. They don't have enough evidence to tell us to use this for people who are intubated or for children. And they definitely don't want us to combine the 2 new drugs. Why does this sudden interest in baricitinib? A paper called Cove Barrier Study, where they were able to reduce all-cause mortality by 38% by using baricitinib instead of just plain old steroids. So next slide. And then how about the some vaccine updates in closing? So the Pfizer vaccine, I think everybody's really aware and excited and working hard on getting adolescents, people over age 12, vaccinated with the Pfizer vaccine. The good news from the announcement at the bottom of the page there in yellow is that you now don't have to worry about co-administration with other vaccines. So you could, for instance, in the right season, give a flu vaccine or an MMR vaccine along with this COVID-19 vaccine. So that's really nice. They stated in this announcement that the booster doses, the need for a booster dose has not been determined. There is some research going into this, and we may all be learning about that soon. And they did also state that the COVID vaccine can be given to pregnant or lactating women. So nice developments, kind of things that we worried about 5 months ago, 6 months ago. We don't have to worry so much anymore. They did put out a warning about the Janssen vaccine, or so-called the J&J vaccine. And they found that there were 7 cases of thrombocytopenic thrombosis syndrome in women who were aged 18 to 49 versus 0.9 per million in women who are older than age 50. So that's a group you should be aware that there is some risk of clot, albeit small, but increased above baseline. We should definitely avoid this vaccine if there's a history of heparin-induced thrombocytopenia, since these syndromes are similar. And also, they also said not to use aspirin or anticoagulants for the general population. So a little update, it's worth looking at that link there at the bottom of the page about this vaccine. Next slide, please. And then this is the big news, is that if you're fully vaccinated, you can resume activities that you did before the pandemic. And you can see on the right in the green column, there's lots of smiley faces, and in the left, we find that going to the barber shop is still less safe, and going to a indoor movie theater or attending a church service is least safe. So this is a good publicity slide, I think, for encouraging our patients that we care for in the health service to get vaccinated. Next slide, please. And then why is the CDC and ACIP so excited about the vaccine and telling us we can kind of crank down our prevention? Yet more data has come out showing that the Pfizer and the Moderna vaccines are incredibly protective in this study among healthcare personnel. So this was a national test negative design case control study in 33 sites, 25 states, mostly inpatient healthcare providers. And these are people who came in to their outpatient occupational health clinics with symptoms. They were tested, and those who were tested negative became controls. Those who tested positive became the cases. And they did this at a ratio of 3 to 1. And what they found was that after a single dose, they had 82% effectiveness. And at 2 doses, they had 93.4 effectiveness after 2 doses. So this is real world evidence that this vaccine is incredibly potent. And so you can feel really confident in using this vaccine and encouraging it for your patients. Next slide, please. So how about this concept of myocarditis after mRNA vaccines? The CDC VAST, or Vaccine Safety Technical Work Group, put out a nice technical report that came out on the 17th of May. And they reviewed several presentations on myocarditis after the messenger RNA vaccine. They concluded that there were relatively few reports. It's primarily in adolescents and young adults. Males seem to have it more than females. It's more common after the 2nd dose and usually within 4 days of vaccination. Most cases are mild. And what they stated was that the rates of myocarditis reports have not differed from the expected baseline rates. So something to be aware of. You may have some discussions with your patients, but not something that is proven to be a big hazard at this point anyway. Next slide, please. So I mentioned that we're winding down this series of COVID-19 updates, and how are we all going to stay up to date as we go forward? Well, I'm going to spend a lot of time using the NIH guidelines, which you can get at that web link there at the bottom of the page. They also have a beautiful app that you can download that has the guidelines easily accessible. There's also the Brigham and Women's COVID protocols. They have a really nice app that you can also use. And you might want to use the ID Society's guidelines, which are updated frequently. They're really excellent, top-notch sources of information. Next slide, please. So I wanted to close out on this upbeat note on a nice sign that's just outside my family's village. This is in the jungle. You can see there's a lot of ferns. I think there's rhododendron in the background in this area. And this is put out by the Konoma Student Union. It says, wherever you go, no matter what the weather, always bring your own sunshine. So good news for us coming out of the COVID pandemic in Indian country. We made it through. Congratulations, Indian Health Service. And now you can move on, bring your own sunshine along. Thank you very much.
Thanks, Dr. Irlu, and that what a fantastic image to finish out the last clinical update on. There's a quick question from Dr. Strominger, who asked, do you have anything to report about, or what have you seen with regards to the durability of the vaccine and the immunity provided? Specifically, most of us, he points out, are at about 5 to 6 months post-vaccine right now. And would you anticipate any change in recommendations with regard to work-based PPE and social behaviors?
Yeah, so what we're told is that there will be some data by sometime in September, and I heard a prediction from Dr. Fauci that we might be revisiting like an annual vaccine starting this winter, when we'll know for sure. But this is all rumor. I was made aware that there are some clinical trials in progress with the messenger RNA vaccines to see the durability of response and see if a booster would be indicated. So, right, in terms of PPE in the hospitals, I think we're all coming to a point where we will be ramping down PPE and taking care of people who've been doubly vaccinated and we're out 2 weeks. There will be some changes coming out, but they're slowly from the CDC. You'll have to wait a little while.
We will stay tuned. That's the last time I'll be asking you to look into a crystal ball publicly for a while. But on a personal note, just have to say thank you very much for these clinical updates in the past 15 months. I'll speak for myself, though I suspect it's for a larger audience, that as a clinician, there's no way I could have kept up with the information at the pace it was coming through. And the work that you've put into these updates and boiling it down to these bullet point pieces of information that we need have put us all in a better position to take care of our patients and ourselves in the past year. And I know it's been a lot of work. So thank you very much, Dr. Irlu. Really, really appreciate it.
You're welcome. Thank you for the chance.
And I'm very pleased to now introduce our presenter, Dr. Jeffrey Manival, who's joining us from Brigham and Women's Hospital Division of Cognitive and Behavioral Neurology from the Center for Brain and Mind Medicine. Dr. Manival did his residency at the University of Vermont Medical Center, followed by a fellowship at Brigham and Women's Hospital in behavioral neurology and neuropsychiatry. And we're very excited to hear about considerations in the long-term COVID effects on the neurologic system. Dr. Manival, thanks so much for taking time out of your schedule to join us today.
Absolutely, my pleasure. It is such a wonderful opportunity and such a wonderful gift to be able to talk with you guys from the Indian Health Service. You do such amazing work, and I am very happy to join all of you today. So let's get started. So I have no financial disclosures or any conflicts of interest with any of the presented material, certainly in this presentation. So as learning objectives go, we'll go through the neurologic symptoms most commonly seen in COVID patients and in post-COVID syndromes. And we'll touch on some of the methodologic challenges with the multiple phenotypes of the neurologic function dysfunction that we're seeing in these patients. I'll go over the overlap between the post-COVID syndrome and chronic fatigue syndrome, as well as the diagnosis and treatment. And then I'll finish up by talking a little bit about COVID headache and brain fog and discussing the role of an interdisciplinary approach for addressing these difficulties. So unfortunately, right now, there's no one way of defining our population. So some folks call this long COVID, long haul COVID-19, post-COVID syndrome, chronic COVID syndrome, and then even post-acute sequelae of SARS-CoV-2 infection, or PASC for short. So you'll see these different terms all within the literature. So when we're looking at our syndromes, methodologically, and this is coming from me, this is not necessarily described in the literature yet, that we're using this post-whole COVID neurologic sequelae to talk about a couple of different phenotypes, a couple of different syndromes. So I've split these up into 3 different syndromes, and I'll touch on 2 of these in the most detail. So the first being that there's the COVID infection, and that leads to some type of sequelae, either direct invasion of the brain causing an encephalitis, inflammation of the blood vessels, Guillain-Barré syndrome and Miller-Fisher variant can be seen. There can be cranial nerve abnormalities, stroke, and thrombosis. But in folks with difficulty with hospitalizations for COVID, you can also have sequelae of just having critical illnesses. So you can have affective disorders, you can have a critical illness myopathy, there can be pressure and nerve injuries related to the positioning, and then you can get a toxic metabolic encephalopathy just from being very sick, and especially in the intensive care unit. Apart from these syndromes, we're also starting to see folks with what has been characterized as long-haul COVID. So they have a variety of symptoms, anosmia, brain fog, headache, numbness and tingling, anxiety, and fatigue that that may not be explained by either of the 2 preceding groups. So these folks might have had a very mild form of COVID if they tested positive at all, and come down with these longer term symptoms. So when we look at the immediate neurologic complications of COVID, so in the first group that I was talking about, we see that these can happen at almost any time. So you can see over here that, for example, Guillain-Barré syndrome can actually precede the onset of the respiratory and systemic symptoms of COVID. And you can see a variety of these complications at various timeframes around the onset of the respiratory symptoms of COVID. So this has been in the literature described as having an encephalitis. So up here you can see inflammation of the right medial temporal lobe. You can have a necrotizing encephalopathy, and you can certainly have cerebrovascular disease and stroke. And so in this patient, you can see a stroke in the left occipital cortex. So the first longitudinal studies have come out from China, actually from the folks over there, and they found that in hospitalized patients, about 63% had severe fatigue and myalgias at 6 months out. 26% had sleep difficulties, and 23% had anxiety and depression. 6 months after their hospitalization. And the main point of this article is that there's some challenges with defining these folks with seropositive and seronegative status. So as you can see, they measure antibodies, IgM, IgA, and IgG against the nucleoprotein, the receptor binding domain of the spike protein, and the spike protein itself. And as you can see in these follow-up groups, you can see that the amount of the antibodies have shifted lower, and some have even shifted below cutoff. And so they noted that there may be a decline in the antibody titers even as far out as 3 to 5 months after these folks have been sick with COVID. And that produces some even increasing methodologic considerations when we're trying to evaluate these kind of long haul COVID patients. So does COVID actually enter the cerebrospinal fluid and can it be found in the CSF? So while case reports have noted that there's been that the RNA has been located in the CSF, there's been studies looking at hospitalized patients with lumbar punctures and postmortem, and they have not, for the vast majority, have not found that there's evidence of frequent invasion of the cerebrospinal fluid with the virus. The anosmia that people get, which is very common for folks after they have COVID, may be induced by inflammation rather than in direct invasion of the nervous system. And so while there are case reports of people with encephalitis and evidence of direct invasion, it's difficult to know what to make of these because those folks, the lumbar puncture may have been traumatic and may have been a blood exposure. So but overall, it does seem that the SARS-CoV virus does not routinely enter the cerebrospinal fluid in most patients. So for the first group of people, the folks who had the COVID virus and developed neurologic sequelae while hospitalized, we don't have actually too much data right now, but the biggest registry that has looked at folks over in New York found that there was a toxic metabolic encephalopathy in about 7% of folks. 2% had stroke, the majority, of course, being ischemic stroke. 2%, close to 2% had seizures, most without a history of having seizures. There's been hypoxic and ischemic injury, again, dropping blood pressures and signs of systemic diseases. And there's been a variety of other neurologic sequelae that have been much less rare. Guillain-Barré syndrome, myopathies and neuropathies, and even movement disorders. Of note, in this population, there were no cases of encephalitis or meningitis or even a myelopathy that was directly attributable to COVID, although this has been described in the literature and case reports. Of those with neurologic sequelae, 69% developed prior to hospitalization, and 2% developed symptoms as their first presenting symptom. The folks that were the most sick and the most prone to getting the neurologic sequelae were those folks who were sicker. So folks who were a little bit older, men, folks with comorbidities like hypertension, diabetes, and AFib, and those with higher sequential organ failure assessment scores or SOFA. So this is not perfect. It did not include folks who had not had neurology consultation, and people who were in the intensive care unit and sedated. So it may be drastically underestimating the number of toxic metabolic encephalopathies, and certainly it may not have picked up on some of the more minor or mild symptoms. But at least this gives us a little bit of an idea of the frequency of these direct neurologic sequelae. So in non-hospitalized patients, a recent study came from a clinic who actually opened up for the former reason. So they opened up because they were anticipating that a lot of folks who were hospitalized and had Guillain-Barré syndrome and stroke and all of these other things would have a lot of sequelae that would need to be evaluated. But actually, they were overwhelmed with folks who hadn't really been hospitalized, who had much more mild symptoms, if at all. And they separated these folks into seropositivity and seronegativity. And so again, getting back to what I mentioned earlier with the seropositive nature, it's a little bit challenging to make too much out of that. So it's kind of comparing two sides of the same coin, and there's quite a few confounding, but they did find that the folks were predominantly female and white, that there was depression and anxiety, that suggested some type of neuropsychiatric vulnerability, and that they had a very high rate of fatigue, brain fog, and the authors questioned whether this could be an autoimmune reaction to the mild case of the virus, whether it could be lingering reservoir of the virus, or even functional neurologic disorder. So that brought up this idea that long haul COVID and chronic fatigue syndrome may be intimately related in some ways. And so in one study, 25 out of 29 of these long haul COVID patients reported all of the major criteria for chronic fatigue syndrome. And the minor criteria were all very well represented. And so the authors here brought up a potentially similar pathophysiologic mechanism for inducing this type of phenotype. And so the thought would be that there would be an overlap between the pathophysiology and the treatment of these folks. And so to define, for those of us who may not have seen this too much, chronic fatigue syndrome is defined by impairment in occupational, education, social, and personal function for over 6 months. So again, we're not at that 6 month, we're not at the place where we're able to publish more than 6 months out from the virus yet, but these studies will probably start coming in the near future. There's significant fatigue, post-exertional malaise, and unrefreshing sleep, along with cognitive impairment and or orthostatic intolerance. So why hear it from me when you can actually hear it from Dr. Fauci?
When you talk about what do you mean by seriously ill, there are many, many young people who get infected. They get sick. They feel horrible for weeks and weeks. And then one thing they notice, and we're getting a lot more information on this, that even when they clear the virus and they test negative and they don't have any virus, they can feel out of sorts for weeks and weeks, almost similar to a myalgic encephalitis chronic fatigue syndrome thing, where they just don't feel right for weeks and weeks and weeks. When you talk about what do you mean by seriously ill, there are many.
Here we go. So how do you approach these folks? So certainly it makes a big difference to take a very careful history, try to determine if there are any other comorbid conditions, anemia, chronic kidney disease, abnormalities in glucose or diabetes, thyroid dysfunction, celiac disease, sleep apnea that may be contributing to some of these symptoms, and to take a very careful neurologic exam. And if there is a abnormality on neurologic exam, our practice is to do neuroimaging at that point. There is an argument also to be made that some people will make the argument that even in folks who have all these cognitive fog and have such significant occupational functioning, that a one-time MRI or a CAT scan is helpful to just rule out other kind of rare presentations, such as a small stroke in one of the brain areas that's responsible for memory, or a tumor, or one of those other things, just to make sure that everything is looking fine, and to reassure the patient when it's been affecting their lives so much. This is a extremely controversial condition, and I think it is important to just briefly mention that before I kind of get into a little bit more of the possible treatments for this. These folks are very vulnerable, and there are a lot of psychological based factors that may be kind of self-exacerbating. So the dysphoria that people are experiencing may be solidified and encouraged by a retreat from their typical daily function. And so some people will characterize this as an exacerbation of internal distress with which can be seen in a very similar light as chronic Lyme disease or post-concussive syndrome, or even on the personality trait spectrum. That being said, another group of folks would label this instead as being something that is much more along the lines of a autoimmune reaction that is causing significant fatigue. And so there is, this is quite controversial. As part of the PACE trial, which has been the largest trial looking at folks with chronic fatigue syndrome. And I think it's the reason why I'm getting into chronic fatigue syndrome treatment is because we don't have any other lines right now to indicate other forms of treatment other than for chronic fatigue syndrome. I'll talk a little bit about different medications and drugs that are being used in post-COVID clinics over at MGH and at Mayo and in other areas, but these are all symptomatic treatments that don't have a strong evidence basis quite yet. And so I'll go a little bit into the treatment for chronic fatigue syndrome just to provide a little bit of a background for the current management of these patients, knowing full well that the phenotype of long-haul COVID may be different than chronic fatigue syndrome, and will over time be able to separate those folks out a little bit more. And a lot of research is kind of heading in this direction. So for chronic fatigue syndrome, they don't seem to tolerate vigorous aerobic exercise. And the real crux of this is to avoid overdoing it. So pacing, not leaving the energy envelope, and involving rehab specialists, occupational therapists, and exercise physiologists who are specialists in fatigue. They may need additional devices, wheelchairs, and other devices for additional assistance in getting through their daily activities. And stimulants can be trialed, but sometimes can exacerbate the underlying post-exertional malaise that some of these patients can experience. And so, as a brief side note, I've tried methylphenidate and actually all three of these stimulants in these folks, and have had really quite varying success with it. And that's to mean that I have not had great success with it, aside from a few cases. Sleep can be treated with sleep hygiene, managing expectations, ruling out other sleep disorders, and then sleep pharmacotherapy with melatonin, trazodone, and tramadol. I would be hesitant again to go with benzodiazepines in this patient population. Pain can be treated with physical therapy and occupational therapy, acupuncture, massage heat packs, and other things. Cognitive fog can be evaluated with memory aids. The Pomodoro method is is my personal favorite. Although again, the Pomodoro method is basically working up their ability to concentrate over time. So taking very regularly scheduled breaks and then working up the amount of time that they're able to between those breaks. That being said, that also may trigger this kind of post-exertional malaise phenotype. And so they have to kind of know themselves and experiment with their limits. For screening for folks in the clinic, AMOCA is a pretty good screening test for things that can mimic the cognitive fog and to get a little bit of a better baseline for the patient. So things that people have difficulties with include the visuospatial function and executive tasks, the cube copy, and the oral trails task. Again, kind of putting the localizing effect of this to the frontal part of the brains and the frontal kind of complex attention networks. Memory can be affected both with encoding and retrieval, and it's especially helpful to get down here, use category cues and multiple choice cues. And so if the person is remembering the items with a category cue and a multiple choice cue, that means that their memory storage has been relatively unaffected, and it points you away from, for example, an insidious dementia, Alzheimer's disease, and really puts the focus on this long haul COVID cognitive fog syndrome. Depression and anxiety might be reactive, and people can use psychotherapy and SNRIs, venlafaxine, duloxetine. I've had a little bit more anecdotal experience with duloxetine as something that helps the depression and helps a lot of the pain that these folks are in. People can have real changes in tilt table tests and orthostatic intolerance, And so increasing fluids, electrolyte salts, and beta blockers for those who have a little bit more of a POTS phenotype, as well as fludrocortisone and other things to bring up the blood pressure as needed. So interestingly, there has been a lot that has been case reported about headaches, but no real good data. We don't have a lot of great data yet. And so overall, there are multiple phenotypes that have been seen in both these post-COVID patients as well as the severe hospitalized patients. In fact, headache was present in up to 60% of non-hospitalized patients that would be under the kind of the long haul syndrome of COVID. The differentiating characteristics here included an anosmia, which actually had an odds ratio of 11.1. The bilateral pain, analgesic resistance, and GI symptoms, in differentiating this from more common prototypical migraine. So the fact that if a patient presents to you with a new headache and it's analgesic resistant and it's associated with anosmia, that points you much more towards this post-COVID headache rather than points you towards kind of an exacerbation of their underlying migraine. Of note, and this is pretty interesting, a headache specialist actually got COVID and published a case report of himself showing that the characteristics of the headache could change and several different headache phenotypes could be different at different times during the COVID infection. Some of these headaches are so severe that it has even triggered suicidal ideation. So this post-COVID headache syndrome can be pretty severe, and there's unfortunately no data to guide our treatment thus far. At MGH, the folks over there have been using small doses of gabapentin at night to help some of, and certainly if have a positive response during the day to treat some of these headache symptoms. And at our center, we've been a little bit more using the tricyclic antidepressants, so nortriptyline and amitriptyline. There are not a lot of great data to guide our treatment right now for the post-headache syndromes in COVID. So what did I want to go over today, and what did I want to impart to the group here? So COVID has a variety of neurologic and neuropsychiatric sequelae. And there's a lot of, there's most likely different syndromes of COVID, which I believe can methodologically complicate the current studies. So there's an acute infection, which can cause systemic effects and then primary neurologic disease. This is the category of stroke, of Guillain-Barré syndrome, of encephalitis in rare cases, but can also cause an encephalopathy that may persist. Then there's another group, another phenotype, which is just any type of person with a critical illness who ends up in the intensive care unit and is intubated will have sequelae. So that includes critical illness myopathies and pressure palsies of nerves, and certainly adjustment disorders. And then there's this long haul COVID syndrome that seems to mimic chronic fatigue syndrome and may be ultimately chronic fatigue syndrome that tends to happen in folks with minimal symptoms of the infection, people who are not hospitalized, but cause a pretty severe occupational and physical decline in functioning. There have been postmortem and lumbar puncture studies that have found that direct CSF invasion is rare, which may inform some of our thoughts on this kind of long haul COVID syndrome. But regardless of the cause of this, multidisciplinary care is just vital for each of these phenotypes. Long haul patients have a lot of pain and may need physical therapy, just as folks with a stroke that stemmed from COVID hypercoagulability will need physical therapy. Occupational therapy and SLP are also very much needed for these folks. given the amount of anxiety and depression and adjustment disorder, many of these folks need therapists, which has led to a pretty significant cognitive fog, sleep disturbance, and headache are quite common, even over half of folks for the incidence for many of these things. And one of the ways that you may know that it is due to COVID is actually that it is refractory to traditional pharmacotherapy. And so right now we use non-supported, non-data-driven symptomatic medications, which would be largely supportive. There is some anecdotal evidence that's not peer-reviewed yet that shows that some patients will improve after vaccine administration. Although this hasn't been peer-reviewed, some of the numbers that I'm seeing have been about a third get better, but there is a substantial proportion of these folks that are getting worse after the vaccine in terms of their long-haul COVID syndromes. There is a potential significant fatigue and this post-haul COVID syndrome that can last weeks to months to perhaps years. I've seen several cases of now over a year of these post-haul COVID syndromes, and again, this may have a psychologic component to it as well. Finally, and most telling for our group here, there may be significant cross-cultural differences in both the neurologic and psychiatric sequelae of our patients. So anecdotally and with studies, we've been seeing that middle-aged white women have been incidentally affected by some of these syndromes more than other, or at least the post-COVID syndrome, a little bit more than other minorities and other folks. Is this because they're coming to medical attention and because of being in Boston in our catchment area, or is there a pretty significant cross-cultural difference in the reaction to the COVID illness? And that is a question that will have to be answered with additional research and additional data. Someone prior to my talk asked me to talk a little bit about the future research directions and things that are opening up. So there have been post-haul COVID clinics that have been opening up kind of all over the United States. We have one at Mass General Hospital. There's been one at the Mayo Clinic. There's one at Beth Israel Deaconess Medical Center. But overall, at least from our department, a lot of these folks are just kind of trickling in through the behavioral neurology and into neurology clinics overall. And these are challenging patients because they have a lot of debility associated with their syndrome, and they have and we don't have a lot of proven data-driven, evidence-based procedures to give them. There is a variety of NIH grants that are currently being doled out at centers all across the East Coast and certainly across the United States. And so hopefully over time, we will learn a little bit more about what treatments have been effective, at least data-driven, the exact proportion of folks who are getting better and potentially worse from the vaccine, and potentially whether these folks are experiencing a chronic fatigue syndrome, and if there is a difference in the phenotype or in the pathophysiology between chronic fatigue syndrome and post-COVID syndrome. So let me stop there.
Presentation at the outset, and namely to help prepare our primary care teams with the tools they need to see that next long-haul COVID patient is presenting with some neurologic symptoms. I think we've absolutely had that and more from your talk. Dr. Irlu had a question, wanted to give him a chance to ask.
Yeah, simple question. So I do some primary care as well as ID care. And when people come into the clinic in the internal medicine practice and they're tired and fatigued after an illness, we are tempted as primary care providers to give them an SSRI, duloxetine, et cetera. Is there any role for doing this in these long COVID patients who are fatigued, but maybe they don't meet all those criteria for CFS, et cetera?
Absolutely. So again, this is all anecdotally based. I've had, unfortunately, more often than not, I've used duloxetine for post-COVID headache syndromes, post-COVID fatigue, and this, chronic fatigue syndrome phenotype. Unfortunately, more often than not, I am not seeing a drastic improvement. And again, this is anecdotal. That being said, I did have at least one patient who comes to mind where she wasn't able to exercise, she wasn't able to really work, and wasn't able to get out of her house, and was essentially homebound. And she had an incredible response to the duloxetine, started working again, thanked me at one point for quote unquote saving her life, which just tells us how much these folks are affected by this COVID syndrome. So anecdotally, I have had some success with it, but unfortunately, that success is few and far between.
Thank you.
Thank you, Dr. Menneval. And just a quick comment, and I was chatting Dr. Irlu on the side about this. Quite interesting, I think, that does not appear to be CNS invasion by COVID. I mean, we've heard of all the systems and everywhere that it makes its way to. And so that was quite interesting to hear that. And I think that's a very concrete piece of information we can take back, at least in the emergency departments and on the inpatient units when we're taking care of these folks, that direct CNS invasion doesn't seem to be a part of what's going on with COVID.
It's a very interesting anecdote, and again, this doesn't really necessarily pertain to the talk, but it's fascinating. There's been some studies where they've severed the olfactory nucleus in the center for the cranial nerve for smell in animals, in rats, and they've actually found that there's changes in the amygdala, the part of the brain that's responsible for predominantly responsible for emotional regulation and emotions. And so it's very interesting to think that if there, for whatever reason, it is an inflammatory component or cytokine or direct invasion of that olfactory nucleus that causes damage, whether that could potentially induce changes in the CNS, in the brain, that may contribute to some of the neuropsychiatric and behavioral neurologic effects of COVID. So that certainly hasn't been shown in humans, but the sense of smell is one of those, is fascinating because it's an evolutionary trick that it bypasses the normal relay centers in the brain. So in a sense, the olfactory nerve has kind of a straight shot to some of the more conserved centers of emotion and fear in the brain. That is one of those little evolutionary components that has been sustained into modern times.
That's very, very interesting. And yeah, it explains how, I guess, nostalgia is evoked sometimes with smell, possibly. A quick question for our primary care teams as well. What would you recommend as a trigger for a neurology consultation as patients are being seen in the primary care clinic? You've given us a lot of very concrete tools to bring to our practice with regard to supportive care for long-term headaches, that sort of thing. Could you share some examples of what should trigger a neurology consult?
That's a great question. At this point, certainly, if there's any abnormality on the neurologic exam, if there's a concern that there may be another underlying component. So for example, someone comes into you who's 60 years old, and you do a MOCA or a screening test, and you're finding concerning findings such as memory storage disorder, or not able to name things, or difficulty with kind of higher order executive functioning. That, I think, should be ultimately evaluated by a neurologist, because there would be concern for, a stroke or a underlying dementia or something else that would be another syndrome that could be explained, that would explain some of these difficulties. Again, at this point, there may be a role for consultation to a post-COVID center that may be, as we go forward, a little bit more up to date on recommendations or the most and on the most kind of cutting edge research that's coming out of a lot of these long haul clinics. But right now, there's not a significant, this is an indication to refer to neurology. It's based on, is there something else going on, and how the person is, what their physical exam looks like, if there's any other concerning elements on their history.
Thank you. And just out of curiosity, in your practice, have you been seeing folks with long-term neurologic symptoms that would rise to the level of meeting criteria for disability?
For what? I'm sorry. All right. I think we're frozen. Oh, are you back?
I'm back. Sorry, I apologize for that. Yeah, my question was: have you been seeing in your practice folks with symptomatology that would rise to the level of disability?
Absolutely. Several of my patients have not been able to work. They've been on disability. They've risen to such severe financial stressors as, well, one of them actually yesterday ultimately had to leave her home. Had to sell her home to support. And this is a lady who was working in a pretty high functioning position for many years. And so there sometimes is a difference that we're seeing in the severity of what we're seeing on some of the cognitive testing. For example, someone scoring a 26 or 27 out of 30 on the MoCA, but they're telling us that they aren't able to work, they're not able to exercise, they're not able to almost leave the bed. And one the other day even came into my office in a wheelchair. And so there is pretty significant debility. There's a pretty, going on to, again, comparing it to the chronic fatigue syndrome folks, a substantial proportion of chronic fatigue folks are bedbound. And so that's important to kind of keep in the back of our mind that, hopefully as we learn a little bit more about this and to attempt to separate these two potentially different diseases, whether there's treatments that will improve the functioning of these folks.
No, thanks for reminding us of that. I think, some of us who are not neurologists and not in the primary care setting forget how severe the chronic fatigue syndrome can be and how debilitating it is. So thank you for the reminder of the level of disability that it unfortunately imposes on some of our patients. Dr. Glassberg, from the Chief of Critical Care and Sleep Medicine from the Banner University System, had a question. And are we able to allow Dr. Glassberg to unmute for the question?
I think so.
Hey, great to see you. Thank you so much.
Hi,
Dr.
Jeff,
Glassberg.
thank you so much for this enlightening talk. So I really live in the world of pulmonary, as everybody knows that's on the call, but we are seeing some interesting patients in the COVID long-term clinic. We're calling it the recovery clinic to be optimists, but I have to tell you that it's not very optimistic. And a lot of them have neurosymptomatology. The worst is a case of hemicrania migraine. It's like, I, of course, as a pulmonologist, I haven't seen this, but this woman has optic issues, has had to go to, neuro-ophthalmology therapy, sees things upside down. This was an administrator at the hospital. It's unbelievable. And the issue of COVID with her was very interesting because she actually tested negative initially, and then developed some antibodies, got the vaccine, but there has been no change in her symptoms. And she is disabled, can't drive. And the only thing that's in this is COVID. So my question is, have you seen anything like this over in your place?
Yeah, so absolutely. So a lot of those patients are going to headache subspecialty clinics. It's just awful. People, there's the obvious number of, that we see of people who've lost their lives from this, but there's a significant number of folks who have, in all other meanings of the term, lost many of their lives in terms of their uh, uh, functioning capacity. The headaches associated with COVID can be chronic, can be are actually almost by definition refractory to a lot of medications, and can be so severe that people contemplate suicide and have real depression associated with it. So unfortunately, we are seeing folks with pretty severe headache syndromes, and
I think,
someone like that should certainly be in the headache clinic.
yeah, she was put in the headache clinic. She was seen over at Barrow too. We have, Barrow in Phoenix as well as Mayo.
Mhm.
And initially there was some confusion over the diagnosis, far be it from me. I wasn't making any of the diagnoses, but Mayo felt that she had vascular headaches, but the consensus from Barrow and the Banner people were that this was hemicrania. I mean, it's really marked, it's all on one side. And the other thing that happens is there's some kind of cranial nerve involvement where her eye automatically shuts.
Mhm.
So it's like, 3 and 7 are screwed up.
Mhm.
So I guess that's all inflammatory, but we've never seen this with other viral infections. Have
There,
we?
there there are other viral infections that can trigger these things.
Mm,
At least there's been an association between EBV and one of the human herpes viruses that has been associated with a particular phenotype of at least chronic fatigue syndrome. And there are reports that there are post-viral headache syndromes. So
mm,
COVID is certainly the most topical one, but viruses can do strange things with headaches, and even more than that, the person's psychosocial reaction to the virus can do very strange things,
mm.
and so sometimes it's a little bit challenging to tease out.
Thank you.
And Dr. Glassberg, you were way out front in the long haul area of study, and can you hazard a guess as to would the what percentage of folks or let me ask it this way: is the death count at the tip of the iceberg with regard to the kind of the epidemiology in terms of how many folks out there who recovered from COVID may have lasting long haul symptoms, or is it kind of matched with the death number?
I think there's many more long haulers than deaths that we're
Okay.
going to see. I think, I don't know what Jeff thinks, but I think that the long-term ramifications and sequelae and comorbidities and things are, we follow every patient we've discharged, right? So there's thousands of these people. And there are very few. We actually looked at these numbers last week because we're working on the publication. There were 26 out of over 2,000 that were symptom free. So that number alone, right, blows you away, right? 26 out of 2. That's the number. And those were people that could not fit any of the definitions that Jeff showed of long haulers. They didn't fall into any of it because they didn't have anything. And their residual lung stuff had cleared.
And it's important to note out that a lot of these things cannot be, they've looked at CT scans, and that a lot of these fatigue and cognitive symptoms cannot be due to the pulmonary involvement. Unfortunately, the numbers that I've been seeing, and again, anecdotally, unpublished data, is not much better than what you quoted, Dr. Glassberg.
Yeah, Marilyn. I think that the thing is that the pulmonary stuff, Sean, still overwhelms everything else, right? It's still, if we're looking at follow-up scans, chest x-rays, the great majority of these people still have infiltrates. And the questions come up, well, should they be given pulse dosage of short courses of Medrol, prednisone? How should we manage them? Should we try some immunosuppressives? What should we do? I don't think anybody knows. And I think the biggest issue now is the persistent oxygen requirements. That's the issue. And so for our Navajos that are coming in, where we've got to get tanks and stuff to them, there are a lot of them that were not on oxygen that lived at altitude that are now on oxygen. And that's a problem because we don't understand why. We've treated them with Eliquis. We've done all that stuff. We've gone through all of that. We don't know why.
Well, that's a very sobering and clear-eyed perspective, I think, on which to end today's conversation, because it just makes me think that number, 26 out of 2,000 symptom-free. I mean, this is a part of our primary care landscape now. This is a true pre-existing condition that it sounds like everyone in any part of the clinical setting who sees patients needs to get ready for. And unlike other viral syndromes that we're used to, this one stays on their chronic condition part of their problem list. It sounds like.
And I think what we learned today from Jeff is that when we see the chronic fatigue, right, in the primary care setting, we're going to have a different way of looking at it to what we learned today,
Thank you both. Dr. Glassberg, thanks for your insights, and we hope to be hearing from you again on this down the road. Dr. Jeff Manival, thank you so much for taking time out of your schedule to talk to us about the long-term neurologic consequences of COVID-19. As I've said a couple of times, I think you've left us all more well prepared to take care of our next patient that we see in the clinic. We really appreciate your time. Dr. Yerlu, again, thank you for your update today and over the past 15 months. We're going to go ahead. We're a bit over time. I want to thank everyone who stuck around for today's presentation, taking time out of each of your schedule to join us. And on June 17th, we're going to have the final of our clinical readiness and patient care teleeducation sessions in this series. And we'll be talking about where do we go from here, specifically focusing on healthcare worker wellness and moving beyond this acute phase of the pandemic. But I want to remind everyone, it appeared in the chat that the Northwest Area Indian Health Board, I'm sorry, I may have not gotten all of that correct, is still continuing an ECHO program that can be found on the Project ECHO website. So this will not be the end of all of the offerings with regard to COVID-19 content for those folks practicing in and around the IHS system. So please have a look at the Project ECHO website for those. Thanks to the Project ECHO team for keeping us going today and for 15 months, and to IHS headquarters who support these sessions month after month now. So thanks everyone for joining us today. And we look forward to seeing you in 2 weeks from today for the final in this series. Thanks so much, everyone. Really appreciate it.
Thank you.